So we've heard a lot about DPC. I'm an orthopedic surgeon, and I've been kind of pushing this concept of direct specialty care to try and help specialists kind of jump on the transparent pricing bandwagon to serve the direct pay communities. So without further ado, so I altered my talk a little bit after yesterday morning. People often ask me why I champion kind of consumerism as a specialist. Kind of unusual for me to do direct pay. I think people have a hard time finding specialists who offer transparent pricing. So my slide, I had all these bullet points over here, about setting my prices and being paid at time of service and all the great things that direct pay brings us. But I think Jeff Gold said it best yesterday morning on the stage. When he was asked the question, he simply said, I wanted to be a doctor. And I was sitting out there thinking, exactly, right? I mean, that's what we all want to do as physicians. We just want to take care of our patients. We want to serve them, but we also want to be paid a fair fee in a reasonable amount of time. And direct pay really allows us to do that. So I practice in my hometown, and what I've found is a lot of small business owners, so local folks in the community. These are people who are realtors, they own restaurants, they're contractors, and they're people that have disposable income, but they elect not to purchase health insurance because they're spending $30,000, $40,000, $50,000 a year in premiums and deductibles before they see a benefit, right? And these are business people, and they'd rather spend that money elsewhere. They want to invest it back into their business. They want to take their family on a vacation. They want to do other things. And a lot of these folks are my high school friends. And so I learned inadvertently through them that I was turning away cash in my practice. And how did I learn that? These folks were calling my office trying to make an appointment to see me. And when they called, my staff was telling them I only treat insured patients. And this was despite having a piece of paper somewhere with cash prices listed on it. A 99202 or 203 visit is X dollars, an x-ray is Y, an injection is Z. And it was very frustrating because these friends would call me at home at night and say, Mike, tried to get my kid in to see you. They hurt their knee playing football. Your staff wouldn't make me an appointment because I don't have insurance. And I made it clear I'm willing to pay cash. I made it clear that I'm not looking for a freebie because you're my friend. And despite that, they basically wouldn't make me an appointment. And I felt terrible, honestly. I felt these friends of mine were saying, gosh, Mike, you're a doctor now. You're too good for us. You're not going to take care of me and my family. And it was kind of a humbling experience. And so I'd go to the office the next day and I'd say, why couldn't we make Mr. Smith's kid an appointment? And they'd say, oh, sorry, doctor, we didn't know he was your friend. And I would say the same thing every time. I'd say, it doesn't matter. There's somebody that needs our care, that wants to pay cash. We've got cash prices on a piece of paper somewhere. And, I don't understand why we can't make this work. And they'd say, okay, we got it, Mike, no problem. We'll take care of it. But they didn't, right? It happened time and time again. And when we did a deeper dive, I got so frustrated with it. My management team and all of us got together and just said, why can't we get this right? And what we realized is we hadn't really set our staff up for success. It wasn't their fault. It was our fault for really not empowering them to deal with direct payers. And this was the experience I think Jay Kempton talked about yesterday morning when he showed up at the hospital, and the person at the desk just had brain break when they told him they wanted to pay cash, right? And so this happens in all our offices. It happens in a lot of primary care offices too. I'd say the primary care docs are ahead of the game with direct pay and whatnot. But it really happens in a lot of internal medicine offices, family practice, pediatricians. They have the same problem. So what we were asking our staff to do really was, number one, predict the future. You might be able to do that if you have the force, but most of us can't. And so what do I mean by that? What I mean is, for someone to give somebody a price for a good or service, you have to know what you're selling. And so at a doctor's office, the staff didn't know what they were selling. Is it a 5-minute visit? Is it a 105-minute visit? Is it an x-ray? Is it this and that? And so we were asking them to cobble the care together and then calculate a price off our sheet and then negotiate that price with the patient, haggle with them a little bit, try to answer questions. Well, what's that include? Well, I don't know. Very uncomfortable situation for the staff. And so it's quite honestly easier for them to say no. And I thought maybe I was the only one foolish enough to turn away cash. And what I learned was I wasn't. I actually did a study that I presented at the American Academy of Orthopedic Surgeons meeting, peer-reviewed study that showed that 97% of orthopedic practices nationally turn away direct payers. And every one of those practices would say they take cash and they have a self-pay policy. So long and short is we just need to do a better job, I think all across the board as physicians on accommodating direct payers. What is direct specialty care? So we all talk about direct primary care. I mean, based on the Oratium talk, the guy yesterday, I shouldn't have slides anyway. I should just be free-forming up here. So we'll pretend that they're not even there. But primary care, we know what that is, direct primary care. So what's direct specialty care? There's not a monthly subscription, right? As specialists, I think, we see patients, they get better, they leave, and so we're always seeing new folks. So it's not like a primary care where they might need to visit their doctor, twice a year or even more frequently maybe. In our case, they really don't. So a monthly subscription doesn't make sense. There are a growing number of doctors participating in the direct specialty care, not as many as primary care. But the bottom line is what we do is we need to transparently price our services, and to know what that good is that we are selling, we need to bundle them, right? So when someone comes to see me, I'll sell them a knee package if they hurt their knee. A knee package is a visit with a doctor, an x-ray if needed, and a plan to get them feeling better. And it's at a reasonable price that people can afford, but it's also at a price that I feel is fair to me as a physician. Like I said, I want to be paid a fair price for my services in exchange for taking good care of my patients. So that's what direct specialty care is. Sounds pretty simple, right? Like, why doesn't everybody do it? Good question. I mean, that's kind of my mission. I'm out there trying to get my colleagues to start doing this because it just makes a lot of sense. And the market's growing. I think this is one of the things that a lot of people don't understand is the size of this market. Again, a lot of you in here understand it. I don't know how many of you are physicians or specialists in the audience, and this talk was kind of geared towards you if you're here. But it's a real market. So out-of-pocket spending in 2021, $491 billion. Self-funded employer, $800 billion, anywhere from, I hear that number from $600 billion up to $2 trillion. So, it's all over the board, but it's a lot of folks. And it's the larger market than Medicare and Medicaid combined. So I think we all focus on Medicare and Medicaid and try and figure out how we're going to kind of get more blood from the stone there, and it just doesn't happen. Our Medicaid payments went down by another 4% this year, and we spend so much time dealing with regulatory stuff there instead of accommodating a market of willing payers who want to pay for our services. It's really quite ridiculous if you think about it that way. And these folks want a consumer-friendly digital experience. Like, that's the other part of, I think, direct pay. I think if you look at direct primary care practices, the ones I've looked at and my colleagues who do it, they're very accommodating to the patients. They do treat the patients as customers, and I think we've heard that on the stage yesterday. And most doctors don't, honestly. They act like they're too busy to be bothered by the patients who want to get in to see them. We are the only business, I think, in the world that actively tries to turn people away. Let's do digital online appointment scheduling. Well, what if the wrong patient sees me? I'm a knee doctor. I don't want to see somebody that has a hip problem. It's like, it's a patient. Take care of them, refer them to your partner who has hip pain, right? But it's ridiculous how siloed we've made all of ourselves as physicians, even within our own groups. And so patients want Google, Apple, and Amazon, and we're really giving them the technological equivalent of the rotary phone and a fax machine, as illustrated here. I doctored this slide a little to put my website on it because I didn't want to call out the group that had this, but I was looking at a website recently of a potential client that I was going to help with direct pay, and this is the banner ad that came up on their website. Someone referenced fax machines yesterday in medical offices. It's that big banner ad. We've changed our fax numbers effective September 20th, 2022. That's the highlight of their website. It's not, hey, we take great care of patients. Hey, did you hurt your knee? We're doing all this great stuff. What can we do for you to help you? It's we've changed our fax numbers. And so I got a kick out of that when someone said it yesterday because we say that all the time. But when I saw this, I was just like, yeah, there you go. That says a lot. So, not only do our patients want this, the federal government now wants this. When I started down this path and started doing kind of direct pay, direct pricing 10 years ago, roughly, my partners asked me if it was illegal. And a lot of people that kind of I advise on this and help kind of lift their direct pay programs, they still ask me that. They're, Mike, is this illegal? Are we allowed to price our services? Can we sell healthcare online? And the answer is yes. In fact, it's the law now that you have to have transparent pricing. People are afraid to post their pricing. They still are afraid to post their pricing to some degree. But now the government demands it. And I would argue that probably more than 95% of medical practices in the US are not complying with this law, which carries the same penalties as a HIPAA violation, up to $10,000 per instance. So how do you comply with this law? You bundle your services, you transparently price them, and then you can get a good faith estimate in front of a patient. And so now I'm going to just dive in, like, how do you create a direct specialty care program for you specialists in the audience here? And we'll kind of go through this step by step. I don't have a lot of time here this morning, but I just wanted to show you how this can be done, because a lot of folks I talk to that ask me how to do this, they don't know how to bundle their services, they don't know how to price their services, they don't know how to get them in front of patients, they don't know how to build relationships with the folks in their community, and now, more of the payers, and as these self-funded plans grow, and this whole free market medical association ecosystem grows, how do we connect with that? So we start by creating a consumer-friendly digital experience, right? That's what the patients want. How do they access care? We'll get it on your website. So digital front door, get patients in with an appointment scheduling app, things like that. But then you need to bundle and price your services. Put a pricing tab on your website. You can call it whatever you want. I think Keith Smith has been obviously a pioneer in all this. And on their website, they have pricing, right? That's what it's called. Very simple, but you can call it whatever you want. And then make it easy for the patients. They can purchase online. The staff can send a link for them to buy a package. You want to really make this consumer-centric. I mean, in my practice, we try and give the consumer the same experience that they'd have on Apple or on Amazon when they're purchasing a plan. And so patients love this experience. What's it look like? I mean, just a couple examples of groups who are doing this. They have a landing page on their website for pricing with various locations and whatnot, where patients can get a nice message. If you're uninsured, you're in a sharing ministry and other things, we can help you out. We've got your back. We're gonna offer you fair, transparent pricing. You can look at it on an iPhone. I want to call out a local orthopedic practice, Kansas City Orthopedic Associates, who kind of just went live with this solution that we helped them with. And so they're in the market. Any local Kansas DPCs in the market or that are in the room here, you can connect with KC Orthopedic Alliance and get some of your patients in to see them for a fair price. We create marketplace pages for each service. So a lot of people just say, well, a generic office visit is X. But then it's hard to figure out what's included. And so in orthopedics, patients want to shop by symptom. I hurt my shoulder. If you just tell them an office visit, they're not sure what they're going to get. They call with questions. So you give them a shoulder care, initial evaluation. Includes an x-ray, includes time with the doctor, includes a plan to get you feeling better, and that's all spelled out when patients take a deeper dive. Surgery packages. So if you're a surgery specialist, like I am as an orthopedic surgery, the good news is only about 1 in 10 of our patients that walk in our office really need surgery. We don't, this is a whole nother talk, but we don't do a good job as orthopedic surgeons of billing ourselves as the primary care docs of the musculoskeletal system, but 9 out of 10 times that's what we're doing. 1 out of 10 times maybe someone needs a surgery nationally. But if you're doing surgery, you need a consumer-centric description, right? So rotator cuff repair, there's the price. I mean, and that price looks pretty expensive, but that includes the surgeon, the facility, the implants, the anesthesia. And if you compare that to a hospital price, you'll find that it would be probably 3 or 4 or 5 times higher than that. Real world example, my son, who just graduated from college last year, broke his wrist. He had surgery at the university hospital system where he goes to school. Found a really good hand surgeon up there, and he took great care of him, no question. An open reduction internal fixation of the wrist with most of the practices I work with, it's about $8,000, give or take $1,000. And again, all inclusive, everything. My insurer paid the hospital, and I have a high deductible plan, so I hit my deductible pretty quickly. But just to point out, that other price I just gave is under my deductible. My insurer paid the hospital $42,000 just for facility fees. That did not include the surgeon's fee. That did not include anesthesia. And this is a large, major university hospital system. So, it always kind of rubs me the wrong way, and I hope no one is, not to pick on academic hospitals or hospitals in general, but, we're here for the greater good, but we're going to charge you, 5x market rates to do your surgery. So, and the ridiculous thing about it is the insurance company paid it, honestly. I'd hit my deductible, but, ultimately that money's going to come back out of my premiums and your premiums and everybody else's premiums who's on that large BUCA insurer. So again, I'll get off my soapbox on that, but I mean, that's really kind of the delta I think we're all working towards, is how do we keep people, we heard it all day yesterday, into more independent facilities, out of the hospital, surgery centers, independent practices, MRI centers, and others. How do patients pay? I mean, this was a hurdle, surprisingly, when I started doing this, you'd think it's like, okay, well, we bundled our services, we priced them, great. Patients come in, we collect the money at the desk. Well, guess what? Again, we've trained our staff to do really nothing but third-party billing and collection. So they forget, they don't know what to do. You're gonna give me cash. How does that work? I mean, it's kind of crazy, honestly. If you compare like our medical practices to a regular, everyday business where people are happy to run a card or take cash. And part of that was just like, well, I don't know, the EMRs tell me you owe us this, but our other list is saying this. And at any rate, a lot of times the money goes uncollected. And that's why the kind of mantra I think in healthcare management is, self-pay equals no pay. And that couldn't be further from the truth. So at any rate, yeah, familiar digital checkout. Patients can pay like they're buying something on Amazon. They pay in advance through this program that we're doing. The money's held in escrow and the practice is paid on the day of service. And so there's no cost to collect. The patients are happy. We're involved in probably 15,000 patient episodes in the last 18 months, and there wasn't a single patient that complained about the price. There wasn't a single patient that complained about the process or the service. The patients get this, as you all know. Again, I'm preaching to the choir here at the FMMA, but usually when I'm talking about this, people look at me like I have two heads. But at any rate, everyone's a winner here. Payment options, staff can send links, simple payment rails, very secure. Payments are split for bundles, all these headaches that make people say no to transparent pricing. Well, how are we going to do that? We can't do that. Oh, I don't want to take a bundled payment and not have to pay anesthesia. It's like, people are giving you money, come on, and it's like, but it's amazing the pushback you get. And so splitting the bundled payments and all that works great. And so what I would tell my colleagues is, for this meeting, a little more appropriate here, is position yourself for the self-insured employers. And so I think, a lot of the DPC docs in my community that are my colleagues there, they're just starting to get into the, self-funded programs, right? Most of the patients they see are the same patients that I see through this program, which is, they're the local small business owners, they're my high school friends I talked about, the contractors, the restaurant owners, the people who now can't access care. So we really started on this journey to give kind of local people access to care for reasonable pricing, and also, quite honestly, drive business to our practice and get outside the third-party payer model. But what we've learned as we've kind of grown this a bit is, we've basically put together a pretty large group of musculoskeletal providers nationally that is an attractive, network, if you will, for the self-funded employers and TPAs and others. And so, again, our goal is to keep folks out of the hospital and be able to get good local care, and hopefully not have to get on an airplane and travel somewhere. And again, kind of what I tell my colleagues is, we now have, about 1,500 orthopedic surgeons working with us on this program. And we're at a position now where we can help navigate patients in their markets from the self-funded employers back to their practice. So again, start by serving your local community. That's a large market that most people miss. And then once you start doing that and you have the transparent pricing and other things, now you can start accommodating some of these other markets, right, that we're seeing kind of through Health Rosetta and some of the other things and some of the programs that FMMA has been extolling the virtues of for years and years. And so really, it's kind of common sense, but common sense is not very common, as they say. And so, here we are. The last thing I'll say is on a revenue side. So, I mean, this is a win-win-win. I mean, the patients win because they get access to care for a reasonable price. And the patients win, or the payers in a self-funded program, because they're getting reasonable price care. But the practice wins too, right? I think a lot of people conflate self-pay with charity care. We still do charity care in my office. We do a lot of it, honestly. And we're happy to do that for folks that don't have the means to pay. And I think most practices are. But some pushback I get from people, it's like, well, if we're going to sell to self-payers, why do we want those people? They're going to pay us Medicare rates. And it's like, well, not necessarily. I mean, it's probably, if you're not happy with your Medicare rates, which most people aren't, why would you charge self-payers Medicare? It's like, well, they're charity patients. It's like, no, there's a lot of people willing to pay a fair fee for service. And this is the kind of revenue it can generate. This is 25 doc practice, first 11 months on the platform. They saw 1,350 patients, generated about $450,000 in direct payments and $1.3 million in downstream revenue from their other services. So it is real money. If I could do this 100% direct pay like my primary care colleagues are doing, I would, and I'm working toward that. One doctor in the audience, I won't call him out, but who I met yesterday, amazed, he is doing this like orthopedic surgeon is all direct pay. So I can't call him out, George, back there, but pretty brave and amazing, honestly. And he's in Houston, Texas. So if any of you are TPAs or self-funded plans in Houston, George has transparent pricing for you, and he's all in. So it's really refreshing to see that, and hopefully I can wean myself 100% off the third-party payer system at some point in the near future. But I mean, I can honestly say these are my best patients, and I think you'll hear that from DPC docs. If I could see nothing but direct payers, I'd have a lot fewer headaches. So anyway, that's kind of really all I had to talk about this morning. I know we only had a half hour. I wanted to leave a little time for questions. I'm not sure where we're at, but I'm happy to take some questions from the audience if anybody has some. If anyone wants to talk a little more about it, find me downstairs. Happy to chat. We're helping practices do this. So if you're a specialist and want to learn more, visit with us at our booth downstairs. Or, if you're anyone else, I mean, I'm looking to try and help my clients get more direct pay business. So if anyone downstairs that has a booth, I think I could help you with driving more, giving you a good specialty care at direct prices and help our clients, get more care out there for the patients. So anyway, with that, I'll stop. Any questions, anyone? Yeah, George. I have this funny mic. So.
Texas. Thanks for the excellent presentation. I had a question about the bundles in reference to post-surgical care.
Uh-huh.
Have practices kind of figured out how to, take care of an ACL? It takes 6 to 9 months. Is the bundle do that, or do they have to separate bundles?
So generally, when you're talking about bundled care, you can divide them into what we call a day of service bundle versus kind of a 90-day all-in bundle where you're responsible for everything. Generally, we recommend day of service bundles. They're cleaner, they're easier. We do recommend you provide kind of the 90 days of routine post-op care, so you don't charge for post-op visits in the first 90 days. Out of 90 days, I can tell you just personally, these people have paid me what I feel is a fair fee for my services. Even like an ACL where you're seeing them, you might see them at 6 months, you might see them again at 9 months or a year to clear them. I usually throw in those visits, honestly. But you don't have to. Our practices also have follow-up bundles. So the follow-up bundles are about half the cost of a new patient bundle. So if people are, need to come back a lot after that 90 days, then we'll do the follow-up care. Physical therapy bundles, physical therapy is also bundled. We usually don't recommend including that in the bundle because someone might come to see you, but they live on the other side of Houston and they don't want to fight traffic to do therapy at the clinic that you've, have at your practice or whatever. And so a lot of times we let people do the therapy outside the bundle. Although in my practice, we also sell therapy bundles. So a lot of times someone will buy a 3, 6, 9, 12 visit therapy bundle. The last comment I'll make is people say, well, gosh, what happens? And I hear this from surgeons all the time. What happens if someone got an infection? How do I treat that? And I'm like, well, you treat it like you treat anybody, right? There's no magic to it. But there is a little friction there maybe. People say, well, they'll be upset because they paid for surgery and now they have to pay more. Well, even insured patients are upset if they have complications. But one way that we work around that is we do work with a company, and so we offer complication insurance, if you will, on all the bundles, where you'd be covered for 90 days. Up to a certain amount that, basically these insurers have all the data so they can cover pretty much any complication in those 90 days. So even though you're offering a day of service bundle, you can give the patients peace of mind with kind of a 90-day warranty, if you will. And I would say that payers and employers like that a lot too. So that's what we do in our office. But great question. Yeah, in the back there.
My name is Demetrio Aguilar. I'm a surgeon in the Omaha area. We had cut almost all of the cord except for a little thread up until about, I think it was about 3 years ago we did that. And then this past January, we cut that last thread.
Nice.
My biggest, I have one quick question for you.
Sure.
And then I got a couple other things I'd like to add.
Yeah, sure.
If that's okay.
Yeah,
so
of course.
the question that I have for you is the complication insurance. So we looked into a company, Cosmetisure, to see if we could do something like what you described. And at first they were very interested in working with us until they realized that, oh, wait a minute, you're not talking about cosmetic surgery? Well, we're not going to offer you cosmetic insurance. We're not going to offer you complication insurance if it's not cosmetic surgery. So which company do you guys use to offer that insurance?
Sure. We use a company called Bliss Care.
Bliss Care?
Yeah, I can give you some information. They're out of Utah.
That'd be awesome.
Yeah. But you make a good point on the cosmetics. I often tell my orthopedic colleagues that the plastic surgeons, our plastic surgery colleagues are a lot smarter than we are. They've been doing direct care for ever, 50 years. I don't know how long plastic surgery's been in existence, but it's been direct care. And so that's why these companies exist, for plastic surgery.
Right.
But not other specialties, because it's a newer, kind of the new frontier, I guess.
Right. So one thing that I wanted to mention that, I love what you're doing, and I like the stuff you're doing with the website. One of the great beauties of direct care is that it gives you all kinds of flexibility that you didn't even realize you had before, and this might be something worth considering. Because we're so trained that CPT codes and ICD-10 codes and E&M codes, everything should revolve around that, right? And, and RVUs, and we'll set our pricing based on CPT codes. But one of the beauties of direct care is that you don't have to do anything with CPT codes if you don't want to. And in our practice, a friend of mine suggested to me, he said, Doc, you're kind of a subject matter expert, just like my accountant, just like my lawyer, just like my plumber. Yep. They get paid by the hour. Because what you're really paying for is time and expertise.
Yep.
And whether I'm doing a carpal tunnel or I'm doing an occipital nerve surgery or whatever, my time is still my time, and I still bring to bear the same expertise for all of those different procedures. And so if you want to be really, really radically unconventional, that's kind of the catchphrase in our practice, we're radically unconventional. What we did is we just figured out, okay, well, what should my hourly rate be? How long do I think this procedure is going to take? And then we're just going to price it based on my hourly rate. Yep. Which makes it really easy for the people in our team to calculate how much the surgery is going to cost. I mean, they know that in a matter of seconds. They just, Doc, how long is this going to take? This one will take about 3 hours. Okay, boom, done. There's the price. We'll give them a super bill, so if they want to submit that to their insurance, they can do that. But it makes calculating the numbers way easier. Because the way we did it originally when I first started doing this, we had a spreadsheet that had about 450 different CPT codes that I use for my patients. And then we went through and did reference-based pricing on all of them. I said, no, that price is too high, that one's too low. And then every year when the new pricing would come out, I'd have to assign somebody to spend 3 days just updating the spreadsheet. And I said, that's too much work. Then that friend of mine said, why don't you just do it on an hourly rate? I was like, oh, duh. So I just offer that to anybody here who's thinking about cutting the cord. You don't have to. Just because everybody else does it one way doesn't mean that you're married to that way. Don't be afraid to be different, because you may find that works better for you.
Yeah, no, I agree, and I think that's really insightful about the hourly. I know there's a interesting, I can't remember the name, but there's someone at this conference, I think is an early FMA member, who's a dermatologist, and he had asked a question on the group chat about transparency, and I kind of looked him up and looked at his website, and he does exactly that. He's a dermatologist. He bills by the, and I can't remember what the blocks were, but it was maybe 15-minute increments or something like that. And it was just kind of right there on his website. So you spend 30 minutes, staff calculates the price at the end. And I think the comment you make about CPT and ICD codes is very valuable as well. One of the biggest hurdles that I think a lot of people have in doing this in their own practices, and now when I advise other practices, is people are fixated on the codes. We're addicted to them. Someone said we're all addicted to the insurance, system yesterday. We're addicted to codes. People ask, I don't get it. What do we do? And it's like, well, look, you're still going to dictate an operative note. You're still going to generate an office note. Your EMR is going to create a super bill. There's going to be codes on it. Yeah, it's all good. But they don't mean anything anymore, right? You've agreed to do that for $250. You're going to get $250. you mark it as, paid in full, that, that's your network rate, if you will. I mean, however you want to call it. But one of the biggest struggles we've had, quite honestly, is people trying to wrap their head, trying to take a direct pay program and shove it into the box of what they're doing on the insured side with their EMRs. And I was talking to a surgery center, and they were kind of dumbfounded as to what they would do. Who would they invoice? Like, what do we do with the invoice? I'm like, well, you don't need an invoice because you're paid directly. But who do we invoice? It's like, well, you need an invoice. Can we send it to you? I was like, yeah, send it to us if you want. That's fine. I mean, whatever you want to do. But their system sends invoices. So they had brain break around the fact that they didn't know what to do with their invoice. What are we going to do? We'll just throw it in the garbage, give it to the patient, whatever you want to do. But yeah, you're exactly right. There's all the kind of headaches that we complain about in our practices that exist. People have a hard time weaning off those. And so it is like an addiction, I guess. So, but yeah. Any other questions? Not sure where we're at on time anyway. We're probably running close to 8:30. So anyway, well, thanks everybody for coming. And thanks for the insights from the audience. And it does feel like we're in some sort of Star Wars-esque theme here in this room. So